Today, I would, before we get started with our guest speaker today, I'd like to throw out a reminder to send me your manuscripts for the writing lab, which will be the next two classes, next two Wednesdays. I have one manuscript already, and the more we get, the merrier, so we can all work on these as a group project and apply what we've learned. And don't forget, I'll have a book giveaway also, so if you submit a manuscript, you have a good chance of getting a good book. Okay, I'd like to introduce Raquel Bunge, and she is been working at Houston Methodist for quite some time, but in different capacities. She's a graduate of the UT School of Nursing, and she has extensive experience in the intensive care setting. She started at Houston Methodist in the medical ICU, and she's also worked here at Methodist more recently in a critical, the coronary care unit setting as well. But on top of that, she has a lot of research experience. She has worked with a biotech company with a liver assist device for acute liver failure patients. And she's also run clinical research activity for the CV anesthesia group in the Fondren Brown OR. In 2008, she joined the Research Institute here, and she is the clinical trials manager for the DeBakey Heart and Vascular Center Research Group. She oversees the research groups involved in heart failure, vascular surgery, and cardiac imaging. And she works on a wide range of trials right now, ranging from ventricular assist devices, artificial hearts, new imaging technologies, AV graft surgeries, heart failure drug studies, and new endovascular stents and grafts. So in all of this work, it's very important to know how to report the patient data. And so that's what Raquel will talk about today. Thanks.
Hey. Thank you for inviting me. And I know it's not the most interesting topic all the time, but it's a very necessary one, I believe. So it's very helpful to know the guidelines that you need to follow when reporting patient data. We'll go over why do we have all these regulatory guidelines? Why do we follow these rules? PHI, what is it, and what are the regulations? The regulatory guidelines for reporting data, and what are the Methodist requirements that you'll need to follow here? And then that resources here at Methodist that are available to you. We're going to go over a brief history of clinical research. I always like to know why. We didn't sit in a room and just make up rules for you to follow. I like to say, how can we make it more difficult for everybody to do studies here? So there's a reason for the regulations that we have. So going back in time, we had during World War II, they had these doctor trials during World War II that were done on prisoners in POW camps and the concentration camps, and afterwards they had trials on these doctors that did these experiments, and they developed the Nuremberg codes, where the basic principle is when understanding human research, certain basic principles must be observed in order to satisfy moral, ethical, and legal concepts, and that's what we want to follow now in our research. There are 10 points that came out of the Nuremberg Code. One of the main things is voluntary consent is absolutely mandatory, and that is what we follow today too. We always stress that when we're consenting patients that they know that this is voluntary, they can stop at any time. Research should be done where it yields fruitful results, and it's good for the society. And it should be designed and based on the results of animal experimentation. Avoid all unnecessary physical and mental suffering and injury. One of the things I thought was interesting, the next one, no experimental should be done except like things where the physician would also serve as a subject too. So if you wouldn't want to do the research, you shouldn't ask a patient to do the research also. The degree of risk taken should never exceed that determined by the humanitarian importance of the problem. You're going to have facilities provide that are going to be protecting the subject. Subjects should only be conducted by qualified people, and we also have that in place. That's why we make you go through city course training. If there are device studies, too, that we do here, we make sure that the personnel is trained properly on the device. And then ethical obligations to terminate the research is there if necessary. One of the other big studies here in the United States was the Tuskegee syphilis study. And that study was conducted without due care to its subjects and led to major changes in how we do trials here in the United States. Individuals enrolled in the study did not give their consent. They were not informed of their diagnosis. They were told they had bad blood and they could receive free treatment. And then even when penicillin was an approved treatment for syphilis, the scientists did not give this information to the patients because they wanted to see just the natural progression of the disease, which sounds very unethical. So out of this, it came to this Belmont report, because this Tuskegee syphilis study cited as one of the greatest ethical breaches of trust between the physician and the patients. And so they had this national commission after that in 1979, and it came out with the Belmont report that we follow today.
Isn't it amazing we're talking about 1979?
That's, if you look at the dates, 1932 to 1972, it was a long study. And then,
well, as a member of the IRB, thank you for justifying it. Because sometimes we peeve off investigators. They're not always happy with but the degree to which it's regimented now is perfect.
Right, I agree. And
so quit getting mad at your IRB.
That's right. Everybody's done the city course training, right? Correct? So this should be familiar to you. The Belmont report is one of the things. I'm sure it was a test question on there. But 3 basic principles. You want to have respect for the person, beneficence, the do no harm, maximize the benefit, and justice. So you have fairness of distribution of the research. And these are the principles that we follow in our trials today. Okay. Applications of this is how we follow this is by informed consent. Informed consents are going to give all the information that the patient needs. It's comprehensive and make sure that they know it's voluntary. There's also systematic assessment of the risk and benefits, and that's an important part of the IRB applications. And we don't like to see where you just say, well, the risk or the benefits outweigh the risk, therefore we should do the study. You have to be a little more, elaborate more on that. How do one outweigh the other? And you want to have an equitable selection of your subjects, too. You don't want to just say, I'm going to pick these patients because this is going to make my study results look good. You want to pick all patients that are qualified for the study. So how does this relate to data reporting? One of the big things is protection of your patient, including their information. I know most of the things you're going to be doing is retrospective reviews, so you're just going to be dealing with patient information. But that's still, there's a right that patients have to protect their information. And one of the other things is we want to make sure we're following all the HIPAA laws that came out in 1996. So first of all, with HIPAA, PHI, what is it? It's your protected health information. And they're protected by the FDA Code of Federal Regulations, so there's laws to protect it. And it's basically any identifiable health information. Like I said, it was first passed in 1996. When it first came out, we weren't sure how we were going to deal with it. There were a lot of discussions, a lot of talks about how we're doing this, but now we have it in place. There's set guidelines of how we have to follow these HIPAA guidelines. So this is a list of 18 identifiers that qualifies as PHI. So if you're going to use any of these identifiers in your research, in your retrospective reviews, then that's an identifier. And also note like dates, except the year. You can have a year, but if you have an admission date, a discharge date, a date of death, that can identify a patient. Okay? Even things with fingerprints, device identifiers, serial numbers, any other unique coding except like one that's assigned by the study. So just take a quick look at all that. I won't go over every one, but those are anything that can potentially identify the patient. And it can make a difference between whether your study is considered exempt or expedited, okay, if you have these in your data collection sheets of information you want to collect. So regulatory guidelines for reporting data. We're going to follow institutional policies. Does everybody know how to find the policies here at Methodist? You could go to the Morty website too. There's a link on policies and procedures. It'll link you to Policy Tech. Most people do have an icon on their desktop, but you can look up any policies and procedures for our institution. We're also going to follow the ICH guidelines for good clinical practice. We're going to follow the Office of Human Research Protection guidelines too, and there's a website there that you could go to, and it has really useful videos and links for that. And we're going to follow the FDA. There's a lot of regulations, especially the Code of Federal Regulations. And there's guidance on their website also. So one of the things I know y'all are going to be dealing with more retrospective reviews. I wanted to go over the exempt status because a lot of your studies could follow an exempt or expedited more than full board review. Category 1 of exempt, it just deals with more research conducted in commonly accepted educational settings, so it might really not apply to us, but it's like if you give students one textbook versus the other, or testing, things like that. Category 2, it involves testing, surveys, interviews of procedures, observations of public behavior, except if you obtain that in a way where it identifies a subject, then it's not considered exempt. Or if you disclose information where it could put the subject at risk for criminal or civil liability or financial risk of their financial standing, or if it involves some kind of illegal conduct, drug use, any kind of sexual behavior or alcohol use where it's not conducted in an anonymous fashion to put harm to the subject. So one is like if you're asking outpatients that have diabetes to participate in a focus group and you're going to report about that, but you're not going to have any identifiers. Category 3 involves the use of educational test surveys or observations of public behavior when the human subjects are elected or appointed public officials. I don't know if we'll really have y'all deal with any of that. Category 4, the research involves the collection of study of existing data. Note that existing means before the research is proposed to the Institutional Review Board to determine whether the research is exempt. And that existing data can be documents, specimens, diagnostic testing or specimens, and if these sources are publicly available or the information is recorded by the investigator in such a manner that the subjects cannot be identified.
Will this include chart reviews of existing data?
So no. So this is different. So one of the examples too, like if you're collecting data from a database that where you're not identifying the patients and you're not seeing identifiable information, you're not collecting it, then it would be that. So one of the examples I have is we review the STS database, but we have an STS database manager that provides those data set information with no identifying information. So that would be exempt. Or tissue samples that pathology gives you but no identifying information. But then if you want to review their chart to link them with something, then it would not follow.
Totally different ballgame.
Right. So remember, all this is, it cannot be identified to be this exempt, meet this exempt status. Category 5, the research, another important part about that existing data too. You have to make sure you're saying, I'm going to review this data or these specimens from this specific time point. And it has to be before you submit it to the IRB. You can't go back and say, I want to add to it, because then it's no longer really retrospective, it's prospective. And we'll go over some examples later on, too. Category 5 is research and projects that are conducted by or are subject to the approval of the department. So like your local IRB is going to be the one to approve this. And it's designed to evaluate whether a program has benefit to the society or to the patients. One of the examples is many of your retrospective chart reviews are going to fall into this. But one of the big things is that the information is not collected for non-research purposes. So it's like, again, data that's already been collected. I think one of the RI, I can't remember his name, but he has that Meteor project too, where he was able to pull data like from Method for our faculty members, like to collect information that they're looking at specifically, and then he could pull de-identified data for them also.
There's a lot of databases from which to pull data.
Right.
This guy's pretty good at it.
Oh yeah? Oh good. What's your name? I have to find it. I always need a person that can pull data.
His fees are reasonable.
Oh really? Oh good. So Methodist here, and Dr. Pratt can back me up on this because he's a member of the Methodist IRB. So we have 3 levels of review. You have full board, expedited, and exempt. So full board are going to be more than minimal risk to the subjects. They're not covered under the other.
You've done that cartoon. It looks like it's so hard to get the full board. It's really not hard at all.
I should make it higher, huh?
Maybe turn it upside down.
Yeah. I'll put a second little lady up there, huh? So examples of full board are going to be anything where there's intervention or risk to the patient. So those are mainly our clinical trials that we're involved in. You know, the core valve trials, the new device trials, drug studies. Those are going to be full board. Expedited, there's no greater than minimal risk. And it's like collection of the specimens by non-invasive means. Like we have an example where we collect lung tissue from patients that are having a transplant, and we just want to collect the tissue from the lung that's removed, and that's going to be sent to pathology and then discard it. So we want to collect that tissue. So that's very minimal risk to the patients. They're already having their lung removed and sent, so
So expedited is never a very well done clinical trial that you want to get going on soon.
Right. Won't fit.
Okay. The reason for that here, just for the information for all the fellows, is there are 2 IRBs. There's IRB 1 and 2. I, of course, am a member of our IRB 1, the original, and we added 1, and the wait to get anything reviewed is 2 weeks.
Right.
So that's a long change from 3 months that it was years ago.
Right.
If that ain't expedited enough, you should have done it yesterday.
Yes, and make
I'm
sure
done now.
on your website, on the Morty website too, there's the deadlines for all the IRB 1 or 2. And then just do note that once you go to an IRB, once it's assigned to IRB 1 or 2, that's the one you're going to stay with. You can't go back and say, oh, well, 1's meeting next, and I need to get things back into them. I want them to
you're
review.
automatically delayed a month if you have things to do. If you did a wonderful job writing it, you have 0 days to do it.
Correct. But if they table your application, then you have to wait the next month for that IRB to meet. But expedited, a lot of our retrospective reviews will fall into that. And you still have to submit it the 2 weeks prior to the deadline for the meeting, but then they can review it expeditedly. It's research with existing documents, records collected for non-research purposes in which the subjects are identifiable. Okay. And then exempt, like we talked about, minimal risk. It's going to fit into one of those exempt categories, and it's going to be de-identified. That's the main key. It's de-identified. That will fit into exempt. Any questions about that? So the difference with chart reviews and prospective studies, with retrospective, remember that data has to be existing. You need to set your time when you want to review those records. It needs to be before you submit that to the IRB. So you say, I want to review charts from May 1st, 2012 through May 1st, 2014. That's a true retrospective data study. Prospective is you're collecting them in the future, prospectively. And for those, informed consent is required. Because if those patients are coming in and you're seeing them, there's no reason that you can't get a consent form signed, right? Even though you say it might be easier not to do it, or it is difficult. Believe me, I know it's difficult. We have to do one for our cardiac tumor database too, and we're having to make sure somebody's available to consent the patients. But it's doable, and you have to do that. And also note that some of your trials can be both. They can have a retrospective part to it, and they can have a prospective part to it too. So exempt studies for those retrospective reviews must not have links to the identifiable data. That's one of the main things. Should only be requested if the research involving the collection of the study of existing data, documents, records, specimens, if these sources are publicly available, like we said before, and if the information is recorded in such a manner that you can't identify the patient. It can be expedited, can be granted for those retrospective reviews under Category 5, which are research involving materials that have been collected or will be collected solely for non-research purposes. And it may require a code. Like sometimes, like you have the code that links the, because you'll assign them a study number, but then you have the code that links them back to their patient information.
Question: when people do, there's these papers that are written where people, for example, use database from CMS, and they report on 150,000. Do those things have to go to an IRB, or those are considered in the example that you're talking about? How are those treated? Those type of publications?
Well, I think some things, it depends, like if they're for clinical applications or research too.
No, research.
They're research?
Yeah, you have publications that come out from databases.
So if they're non-identifiable.
Medicare databases, but they are research.
Right.
Yeah.
So if they're non-identifiable, like we talked about the STS database too, we have a manager that provides data to us in a de-identified way, it still went through the IRB, but it's exempt. So it says it's exempt, and you don't have to provide any further information to the IRB.
It will not be.
So the Methodist IRB would approve a study that, let's say, one of us is doing, even if the database is a database that is from CMS.
If you're pulling that information where it's de-identifiable information.
Obviously, CMS have to give you permission.
Right.
But what I'm saying is, does your local IRB have to approve that type of research when in fact you're looking at a database that has thousands of Americans through CMS?
Yes. I mean, I think you do,
Yes.
yes. Because you would have to say that it met the exempt status.
Okay.
But it's just almost acknowledgement. It's not going to go to full board.
Right. Now they'll review it and they'll say it meets the exempt status. When you fill out your application, you'll say, I want exempt status, and then it'll ask you a series of questions. Does it meet this, this, and this? And you can check yes, yes. But they'll review it to make sure it does meet that criteria. And then we still do have to do the renewals for those. You want to keep it open for those. Important tips to keep in mind when completing your applications in WARDI. You want to determine exactly what the dates are that you're going to collect. You want to make sure that they're existing at the time of the IRB submission. The protocol or the application must give those specific dates. One example, too, is what I know we've done it in the past, too, and then they put a stop to it at the IRB, is you have a retrospective review. I say I'm collecting data from 2010 to 2014. Then you go back and say, oh, I want to collect now from 2015 to 2016. At the end of 2016, when it's January 1st, you're like, oh, I want to collect all of 2015 now. And the next year, then you're like, oh, I want to go back and collect that following year. Well, the IRB is not going to allow you to do that because really it's not truly retrospective. You're trying to, get away without doing a consent. But if you're going to add to any retrospective review, it needs to be a prospective arm to that, and you need to get those consents from those patients. Okay, so just make sure that you're specific in those dates. It's all before you're submitting to your IRB, or else you'd have to wait and submit a whole new IRB submission for that following year. You want to upload your study protocol. If charts or clinical information is going to be reviewed, submit a copy of your data collection sheet so the IRB can see exactly what data you're collecting. Describe your statistical analysis, and then also make sure you're going to say whether your data is de-identified, how it's going to be coded, it's anonymous, and everything in your protocol and your data sheets should be consistent with each other. So if you're saying I'm only collecting, their medical history and their CT results, then you can't go back and say, oh, now I'm doing all the labs and I'm going to collect all this additional information. So make sure it's consistent with whatever your data collection sheets and your protocol states you're collecting.
So you can't do that with an amendment?
You could do it with an amendment, but you have to say so.
It's a formalized process.
Right. But it's just easier when you're first submitting, just
do it right the first time.
Do it right the first time. State what you're collecting. And provide that example of that data collection sheet. It's always helpful. You want to estimate the numbers of charts to review and make sure you're staying within that number. If you say, I'm going to review 200 charts, and then you realize you're going to, oh no, now I need to, it's 300, then you need to go back to the IRB and tell them, I need to increase the number. And that's something that's done pretty quickly and can be expedited, but you need to inform them. Because then when you get to your continuing review, they're going to say, how many charts did you review? And then, or your publication, your abstract, you said, we reviewed 500 charts, but then your IRB submission says you're only approved for 200. There's a problem. So you need to make sure that those two numbers are consistent with each other.
That'll be tabled and you lose them.
Yes. But it's easy to fix. You can always just go back and put your amendment in. It's not a big problem. One of the other things, if you're trying to not have a consent for those retrospective reviews, you need to complete the HIPAA waiver sections. And those are, you're going to say why I can't get consent, why it's not feasible for me to go back and get 300 patients to consent that were seen last year. You know, the IRB understands that that's not feasible. It's going to be very difficult to do. So you can explain why it's difficult, why you need this information, how you're going to protect that information, and they can give you a waiver of consent. But either you're getting authorization from the patient to review the data, or you're getting that waiver. One or the other is absolutely necessary for the retrospective reviews. If you are going to use an informed consent form, make sure you're using the IRB approved templates that are on the Morty website. Like I said before, some studies may involve combination of retrospective and prospective reviews. So work closely with your IRB to make sure you're having the requirements filled for both of those. Okay.
I want you to discuss a common scenario because it's frequently one of those that is both. So you want to review retrospective data for the last 3 years in a sample size of 300 patients. You collect all that data. But what you're interested is in some associations of those findings to whether the patient is alive or dead. So then you're going to have to then either go in prospectively and check on death certificates, call patients and families to know if the patient is dead or alive.
Right.
So that would be an example that you treat it as
exactly.
It's a retrospective component, but it's a prospective component that you have to then.
Right, because now you want to see their outcome. You want to see an outcome, and so now you need to contact those patients.
It's a very common scenario where you look into.
Exactly.
Is there any scenario like that where you don't need to get a patient to sign a consent?
Well, you can get a waiver still.
Okay. But what would be the basis of the waiver?
So if let's say it's a large number of patients too, so it would
so you did exactly what Dr. Canema said. You accumulate all this stuff, and now you want to know whether the variables you looked at have anything to do with the patient's outcome at the present time. Okay. Retrospective, prospective. How would you do that?
So you would put in your IRB application that you would want a waiver if it's a large number of patients too that you want to go back to. Say it would be difficult manpower-wise or whatever, that we can't go back and call 300 patients to see how they are. We want to look to see and just review their records to see.
Even permission to call 300 patients.
You could get permission to call them too.
But if you're going to call to find out their outcome, would the IRB have an issue with you doing that without getting a consent?
So we had an example recently, actually, with one of the imaging trials. They did want to go back and find long-term outcomes of these patients that had cardiac CTs. And it was really there were 11 patients. But then we took the scenario, it was 6 years later, and these patients were heart failure patients. Could we find them? Would they be alive? So what we submitted to the IRB was we said, if we could not find them, if we called the number that they had and allowed a family member or somebody that knew the patient, they could let us know general information, like just were they alive or dead. That's basically what we wanted to know.
So you can ask those questions without having a consent to ask those questions?
They gave us a waiver of consent for that one because we just wanted to know whether they were alive or dead. And so the person that answered the phone or that knew the patient they could let us know that information. But it had to go through, and we had to explain why, because some of these patients did pass away. So that's the only way we would be able to find out that information is if they didn't die here at Methodist, if they died somewhere else, how would we ever know? Right?
It's a tough area with the IRB.
It is. there was a lot of going back and forth. It wasn't an easy thing to do. There were a lot of questions we had to answer and how we were, different scenarios that would play out. But we were able to.
Well, a lot of it has to do with your reassurance there'll be total HIPAA protection.
Right. Correct. And then one of the other things is make sure all your study teams, whoever you're adding on your application, that they have completed their COIs and they're credentialed with Citicourse. Because if not, the IRB will not push your study forward. Includes anybody on your study. So if you know that you're going to put several people on your study, that make sure, ask them, did they do their Citicourse? If their COI is not complete, then you probably need to remove them from the study because it'll hold up things. Okay. And with exempt studies, even though you don't have to report adverse events or do your informed consent, you're still under obligation to make sure you have that HIPAA waiver in place before you start doing your retrospective review. Like, don't start doing your retrospective review and then go submit it to the IRB and get your HIPAA waiver. You need to have that in place. Or that authorization from the patient. And more likely, you're going to have that waiver for your retrospective reviews. You're not going to consent or get an authorization from each patient. Okay. But you want to make sure you have that first before you start reviewing your charts. And in order to conduct research here with medical records, you need that, like I said, either the informed consent, the HIPAA authorization, or you're going to need that waiver in place. So basically, the take-home message is waivers required for retrospective chart reviews of no consent or patient authorization. I misspelled authorization. HIPAA, in that application for that waiver, you're going to have to say that what's the adequate plan to protect the identifiers from improper use or disclosure. The IRB wants to know what's your plan to destroy the identifiers at the earliest opportunity. Sometimes if you don't plan to destroy the identifiers, you have to state so and say how you're going to keep that information safe and secure. There has to be adequate written assurance that the PHI will not be reused or disclosed to any other persons. That's not covered in that application. So you say specifically who's going to have access to it. And one of the questions is, tell me who's going to have access to it, how they're going to have access to it, where are they going to store it, how are you going to keep it secure, things like that. So you need to make sure you're having you have that information in. Once the HIPAA waiver is selected, we're going to complete that PHI section on the Morty application. So make sure you're doing that. You want to select. Remember those 18 identifiers. You want to make sure you're putting exactly what you're going to identify. And like I said before, make sure it's consistent on your data collection sheets. If you're saying that you're not collecting date of birth or names, and then you see it, and then the IRB has your data collection sheet that says you're collecting that, then there's a problem. And before the new you submit a new application, it must be complete. So make sure you're filling out all the sections. Your COIs are complete. And one of the other things, if you have prior studies that have expired without you actually closing them, the IRB will look at that when they're reviewing new studies for you. So make sure, like when those continuing reviews are coming around for your studies, that either if you're not doing the study anymore, that you're closing it. That you're saying we're closed, we're done, we're completed. You're just not letting them expire. Okay? Because the IRB will go back and look at your record of how you've submitted studies. Resources here for the ARAF. When you first start a submission, you're going to need to be credentialed. So there's the email for the credentialing office. For the ARAF too, we have a contact information of the analyst there that oversees that part. Once you submit your ARAF, it'll open up your IRB application. And for the IRB, the expedited and exempt studies, Royson Williams is your contact person in the IRB. And then for full board, more than minimal risk, Rebecca Rocha and Weldon George are your contact information. And it's always helpful. I even have them go back and look at my applications too, even though I've been doing this a while. Sometimes it's a very complex study, and I'm like, can you go back, make sure I have everything? Does it look okay? Let them do a quick review before you actually are going to submit it, and they're very helpful with that information. This goes over, so if you have an exempt study, low risk, it's about 2 to 3 weeks. Expedited, medium risk, about 3 to 4 weeks. Full board, higher risk, it's going to be over a month to get your study turned back around. So when you your IRB is reviewing your study, what you'll get back are 4 possible scenarios. You can have approved. They'll send you your IRB letter. Say it's approved. You can start your research. It's going to be approved with modifications. They want a few little changes, and you need to submit those back to them. And then they can do an expedited review and give you your approval letter. Or if they table it, that means there were significant changes that they want, and it's going to go back to the full committee. So then you're going to have to wait a month. But you also need to make sure you're submitting those changes back before the deadline for that next IRB meeting. Okay. Or you can have disapprove, where you just have to scratch it and start all over. Okay.
One of the most common places to have a lot of problems is the way the consent is written.
Right.
And what is in the consent and what isn't in the consent, and what's fair to say about the level of investigation. So
right.
Act like your mom's signing up for the study and read it and see if you understand it.
I always have like a consent. I give it to somebody that's not in the medical field and let them read it, and then I ask them just to mark like what they don't understand or what's
Probably
confusing.
A lot of times they fall asleep and drooled.
That's true. I know most of our consents are like 20 pages.
Yes.
It's like a little book.
I noticed that. Well, that's the problem, that there are so many things that are required now, and yet we say make a consent simple for the at 7th or 8th grade level. And how can you possibly describe some of what we do in the 7th? You can't do it.
Right.
So you do the best you can, and you don't use a lot of any kind of jargon at all.
Right.
No initials. Mm-hmm. You know, don't say we want you to be part of the follow-up of the STS database. That doesn't mean anything.
Right.
For all they know, you're consenting to have a major operation.
Right. It's true. And then also in Morty, you can go back in and check. Give them at least 3 business days after you know that the IRB is met. Give them a little time to turn that around and get those that information back into Morty. Okay. So here's some examples. I wanted to give some examples of trials that we have. And I know one of the fellows is one of your studies is an example on here. So this one in scenarios of what you would do. So you're studying outcomes of off-pump versus on-pump CABG surgery. And this just happened recently, so that's why I'm like, oh, this is a good example. It just happened to me last week. And you have an IRB protocol that falls under the exempt status since you're receiving the de-identified data sets from the STS database. The data is provided by the administrator here at Methodist. So you submit an abstract to a conference and it was accepted for presentation, but you want to add financial data to the results to give it a little more weight on the outcome metrics. The STS database does not provide financial information. So the only way to obtain this financial data is to identify the patients and link them to a hospital financial database. What do you need to do? Do you need to amend your protocol?
Yes.
Yes, right? Will you need a consent form?
Yes.
Not necessarily, right? What can you apply for? That waiver, the waiver of authorization, yes. But you need to explain why you need it. Why can't you go back and collect all the information from those patients in the STS database? And will your study remain an exempt study? No, it's not going to be exempt anymore. It'll be expedited now because now you have identifiable data. So we have to explain to the IRB why we need to do this, why there's no other way to do it, and how now we're going to protect, who's going to access that information, who's going to have the linking codes, and how we're going to protect that PHI. Okay. Another one is project is a retrospective review for up to 10,000 patients who have undergone dialysis access. And we're studying data between January 2007 to January 2015. The study of data will be obtained by conducting review of patients' medical records here at Methodist and in the CV surgery offices. The purpose of this project is to retrospectively review our experience and determine the rates of procedural success and provide.
10,000 shorts?
Yeah.
Wow.
10,000 patients.
Somebody needs to take some Valium.
I know. Our poor little vascular fellows. So this project is going to contribute to scientific knowledge about long-term outcomes associated with this intervention and will help us to improve quality of life for these patients. So we want to review charts now to include patients that were treated in 2015. So what do we need to do?
Prospective. So you have to.
An amendment.
Right?
You just want to.
No, but you're just reviewing, and right now we're in August, but you're applying for January. We're January 20th.
No, but you want to go all through 2015. Let me clarify. So I want to collect all the.
To the end of 2015.
Yes. I want to collect now from going from January 31st or now through the end of 2015.
Amend.
Right. So you need to amend your protocol. It's no longer just retrospective. This is going to be a combination now. So you have a retrospective part, and now you're going to have a prospective part. And you will need to consent those patients that are in the prospective arm because you're seeing those patients come into clinic, you're treating them in surgery. There's no reason that you cannot consent those patients.
They have identifiers.
Right. And it's a very simple consent form. This is not going to be your 20 page consent form. It'll probably be just 3 or 4 pages, and it's saying, we're going to collect your data that's normally collected. There's nothing investigational, nothing interventional going on, but they have to sign that, yes, you can collect my information. So the purpose of this study is to determine whether troponin T measured with a high sensitivity assay and NT-proBNP levels will individually and in concert predict those patients at high risk of rehospitalization for heart failure. So approximately 150 patients admitted to Methodist with a primary diagnosis of heart failure will be asked to give blood samples for the measurement of troponin T and NT-proBNP. And the results from the study may lead to novel biomarker-guided approach for the management of heart failure. Would this be an exempt study? And you can't answer this, I think. That's his study that he worked on.
What's the question?
So would this be an exempt study?
No, you're prospective.
Right.
So you have exemption.
And what is it? Is it minimal risk or, it is minimal, but you're doing an intervention, you're drawing blood from them, right?
So that's low to moderate.
Right. And you're reviewing their chart, right? You're getting information. They're identifiable. Would you need to consent patients for this if you're just taking a little blood sample? Right.
Yeah.
Yes.
Because a little blood leads to a lot of blood.
Yeah. And there are risks to blood samples, bruising, a little pain, discomfort. So you have to put that in your consent form. And that was it.
Trauma. PTSD.
That's right.
Fellows stuck in-
Any questions? Okay.
Good.